Assalamu alaikum and good morning. We are going to start our 20th Shaukat Khanum Annual Symposium Neuro-Oncology session. I welcome you all. I am Dr. Sumaira Bhatt. I am one of the clinical oncologists working at Shaukat Khanum. And our team also include Dr. Irfan Yusuf, who has joined us today. He's our neurosurgeon. Keeping up the tradition, neuro-oncology session is always a very well-attended session. And we always make sure that we cover the new updates in the field of neuro-oncology. As you know, things are changing very rapidly. And in order to make sure that we keep ourselves up to date, these symposiums are extremely important for our development. We are joined by an esteemed member of panelists, which include Dr. Atharinam, Dr. Ahmed Ghilani, Professor Dr. Adnan Jabar, and Dr. Adam Green. We will start our session from a talk of Dr. Ahmed Ghilani, and who is going to cover the molecular updates in the field of neuro-oncology. Dr. Ahmed Ghilani is an assistant professor of neuropathology at the University of Colorado, Denver. He is a graduate from Aga Khan Medical University in 2004, after which he pursued his master's degree and completed his PhD in neurobiology. He's also a trained neuropathologist and has many publications related to this field under his name. I'm going to welcome Dr. Ahmed Ghilani to give a talk. Thank you.
Good afternoon. I'd like to thank the organizers, especially Dr. Sumaira Bhatt, for the invitation to present at this forum. Please share my screen now. I'd like to talk about the changes to CNS tumor classification since the release of the WHO classification system in 2016. Right, these are my learning objectives. I would like to briefly discuss the concept of tumor classification and why classification changes over time. Then I would go on to discuss the most important updates to tumor classifications as addressed in the C-Impact Now publications and in the upcoming WHO classification system 2021, which should be released by the end of this year. I have no financial disclosures. So classification is the operation of distributing objects into classes or groups, which facilitates our understanding of disease and enables us to predict prognosis and therapeutic response in individual cases. For a long time, tumors have been classified based on morphologic appearance under light microscope, which means that the tumors are named based on their resemblance with normal cells in the central nervous system. If a tumor resembles oligodendroglioma, it's called an oligodendroglioma. If it resembles an astrocytoma, it's called an astrocytoma, and so on. So tumors are currently classified according to the scheme released by the World Health Organization. It was first released in 1979, and currently we are in the fourth revised edition, which was released in 2016. We're expecting to have the fifth edition released in 2021. So while the prior editions of this classification used histology alone as the basis for classification, the 2016 edition came up with the concept of layered integrated diagnosis, which means that the molecular alterations were made into a formal part of the essential diagnostic criteria of several tumor entities. This trend will only gain momentum with the upcoming 2021 classification system. So in the current classification system, you give the tumor a histologic classification and then also add in the molecular information. So the integration of the molecular findings were made possible largely due to the wide availability of inexpensive next generation sequencing, which has led to adoption of genetic sequencing as a routine clinical test in most academic centers, at least in the US. So here I'm showing you the cost of sequencing a genome, which was 100 million, as you can see here, at the release of the third edition of WHO in 2000, and was reduced to 10 million in 2007 and down to a $1,000 in 2016. So many 100 times decrease in cost. So we can use several criteria to classify tumors. We can classify tumors according to their clinical features into, for example, into by age, into pediatric type tumors, adult type tumors by brain region, according to, for example, into posterior fossa tumors, supratentorial tumors, and so on, or by their histology into astrocytoma, embryonal tumors, and so on. We can also classify them according to the presence of molecular alterations in them, for example, into BRAF mutated tumors, FGFR tumors, and so on, or by their DNA methylation profile. So let's look at a particular example of that. Consider a 65-year-old male who presented with seizures, and imaging showed a large enhancing region. On like microscopy, we found an astrocytoma with necrosis and microvascular proliferation. Molecular testing found an IDH wild-type tumor with EGFR amplification, and it also had a unique clustering profile on DNA methylation. So in this example, we can see that that all of the different features or criteria come together nicely, and we can call this into a glioblastoma IDH wild type. So, but what if all of these criteria do not match each other? The tumor has features of some of these, but not others. So consider this 14-year-old male with a large heterogeneous mass in the parietal occipital region. On under the microscope, we found a glial tumor with some sort of perivascular arrangement, which led us to consider a REL-A fused supratentorial ependymoma. So looking at the immunohistochemistry, we confirmed its nature as a glial tumor. It was low grade with low MIB1 index, had SOX10 positivity indicating a glial tumor. And since we were thinking about a REL-A fused tumor, we looked for L1-CAM, a surrogate marker of that fusion, and found it to be positive. So we were hoping to find a C11 or RELA fusion, but NGS did not find that. And instead of that, we found this CHD7 fusion with VGLL3 gene, which is a very rare alteration, but has previously been reported in a few cases of hybrid schwannoma and perineuromas. So gene fusion associated with peripheral nerve sheath tumors. So in this case, we see that the clinical features and the histology favored an ependymoma, while the fusion profile or the NGS favored a schwannoma instead. So we also looked at methylation profile of this tumor and found that that methylation also confirmed it being a schwannoma. So this is an example of a case in which the histology and clinical features and the molecular features did not correspond with each other and were kind of conflicting with each other. So in such cases, should we put more weight into certain classification criteria versus the others? And that's a question that still needs to be answered and probably needs more research. Classification also changes with time. As you can see that it reflects our understanding of the disease process, and as the understanding of the process changes, the classification also changes. For example, we currently see a trend towards ever more refined subgroups of disease entities based on new molecular techniques, and also re-evaluation of clinical prognostic data leads to revised grading criteria, and that's what we are seeing with IDH mutant gliomas. So WHO classification is released every 7 to 10 years, but our understanding of tumors is constantly changing. So what should we do in the meantime? And that's in regards to that, the editors of the WHO, including oncologists and neuropathologists, came up with this idea of releasing periodic updates to the WHO, which they called the See Impact Now. So about 7 or 8 of these consensus papers have been released since the release of WHO in 2016, and most of the recommendations published in that series would now be included in the WHO coming out later this year. So if you've been keeping up to date with those See Impact publications, you would find that the upcoming WHO would not be much different. So going over the major changes in the upcoming WHO one by one, the first one is that the new classification now divides gliomas into 2 major categories based on age. One is called the adult type gliomas, and the other one is called pediatric type gliomas. In the adult type gliomas, you have your IDH mutant and IDH wild type tumors, while the pediatric type has your pilocytic, your BRAF mutated, and your histone mutated tumors. Obviously, that's a rough classification. You can still see pediatric type gliomas in adult population and vice versa. The next major change is that the WHO will now recognize that the IDH mutant tumors are completely different animal than the IDH wild type tumors in terms of their clinical behavior, including the overall survival. So we will now use very different nomenclature for these very different groups of tumors. The term glioblastoma, for example, will be restricted or used exclusively for the IDH wild type tumors. So instead of that, the IDH mutant tumors will just be called astrocytoma IDH mutant, and then you would add in the grade, for example, grade 2, 3, or 4. For a long time, we also know that the histologic grading is unable to predict clinical behavior in a wide variety of tumors, including the IDH mutant gliomas. We know that the histologically defined grade 2s and 3s behave very similarly in terms of their clinical overall survival. So since the release of WHO in 2016, we now know that there are certain molecular markers which can be good predictors of tumor behavior. And one such marker which would be recognized in the upcoming WHO is the homozygous deletion of CDKN2A gene. So if the tumor has that alteration, it would be automatically graded a grade 4. So in general, we're seeing this trend towards more emphasis on molecular features and less emphasis on the histologic criteria seen under light microscope. Similarly, for IDH wild type tumors, the previous edition required histologic features like microvascular proliferation or necrosis in order to call an IDH wild type tumor a glioblastoma. But we know that there were several cases which looked low grade under the microscope, but behaved aggressively. For example, this tumor that we had looked low grade or a grade 2 IDH wild type, but behaved like an GBM. So within a span of 8 months, you can see that the tumor radiologically progressed into a high-grade glioma, and the second biopsy 8 months later showed a classic glioblastoma histology as well. So for these tumors, the upcoming WHO will have a separate category called molecularly defined glioblastoma. So even if the tumor has a low-grade histology, if it has certain molecular features, you can upgrade it to a grade 4. And those features include EGFR amplification, loss of chromosome 10 or gain of chromosome 7, and mutation in the TERT promoter. So if the tumor has any one of those features, we now know that it is probably going to behave high grade, even if it shows a low grade histology. So that is also true for many other types of tumors. For example, in meningiomas, the same alterations, CDKN2A and TERT promoter mutation is associated with higher grade. So if the meningioma has any one of those features, it can be automatically called a grade 3. Secondly, we know that certain molecular alterations in meningioma are associated with certain histologic subtypes, such as the clear cell meningioma is associated with SMARCE1 alteration, and the rhabdoid type is associated with a BAP1 mutation or alteration. So those would be now included in the diagnostic criteria for those subtypes. The upcoming WHO will include no less than 22 new entities, and some of which I would talk about now. The histone H3G34R/V tumor, which was previously a provisional entity in the 2016 edition, will now be recognized as a distinct entity. We know that these tumors are present laterally in the cerebral hemispheres. They are more likely to present in the teens or the young adulthood age group, and their prognosis is slightly better than the H3K27M midline gliomas, as reported by several series, including ours shown here. So what's new in the H3K27M mutated midline gliomas? So the important thing there is that the definition has been broadened to include many cases which don't actually show the mutation H3K27 or lysine mutated to methionine. You can still call it an H3K altered tumor if it has EGFR mutation, and these tumors are mostly bithalamic, or it has an overexpression of this gene called EZHIP or EHIP, and all of those this group is as a whole identified by the loss of trimethylation at the histone 3 lysine 27M position, which can be identified by an immunostain. So a broadening of the definition of H3K27M altered tumors to include some groups which were previously not included in this group. Several new entities in low-grade pediatric gliomas have been included, and these are named according to the mutation or fusion that these tumors harbor. For example, there is a new MIB-L1 altered tumor, a MIB altered tumor in FGFR, duplicated tumor in FGFR, mutant tumor, and so on. In terms of ependymomas, there is a new group of ependymoma recently defined, and this is the spinal ependymoma with NMYC amplification. The name of the supratentorial REL-A fused ependymoma has been changed. So we know that this group is marked by the presence of a fusion, usually between C11 open reading frame with REL-A. So the name has been changed into a zinc finger transcription factor, which is the gene present at the C11 open reading frame. So this tumor will now be called a zinc finger transcription factor associated, or ZFTA ependymoma, to reflect the oncogenic driver in this tumor. The classification of medulloblastoma remains essentially the same with the Wnt sonic hedgehog and non-Wnt non-sonic hedgehog groups. Two new embryonal tumors have been included, each named according to the molecular alteration present in them, including FOXR2 or BCOR alterations. And finally, we have DNA methylation-based subgroupings for ATRT and Craniotomy, and both of them have shown very good ability for prognostic stratification. So you can see the key publications for ATRT and Craniotomy subgroups here. So there are a few limitations to this classification scheme, which I would like to highlight here. One is that the nomenclature used in this classification still doesn't have any consistent criteria. You can see that some tumors are named by the genetic alterations that they harbor. Others do not have that in their names. Some have age modifiers, for example, adult type gliomas, pediatric type gliomas. While that is not the case in other tumors, there are location modifiers for some tumors, but not others. So you can see that there's no consistency in how the tumors are named. The rationale presented by the editors is that they would include only the features which have a very clear clinical utility, and only features with that power have been included in the name. So I leave it up to you to decide if you agree with that or not. So in summary, the upcoming WHO 2021 continues the integrated diagnostic paradigm first defined in the 2016 criteria. There is a general emphasis on molecular information in this classification, as was the case in the last classification scheme. There are changes to names in various entities, and several new entities have been included. And we should just realize that this is a work in progress, and there would certainly be changes to this classification in the future. So I would like to thank you for your attention, and I look forward to seeing you in the live conference session in November. Thank you very much.
Dr. Irfan, you're mute.
Thank you very much. So I'll start again. Dr. Ghilani, thank you very much for your excellent talk on the most recent advances in CNS tumor classification. We have come a long way, and now we are heavily dependent on the genetic and molecular markers for subclassification of tumors, which directly bears on the management that we can provide with a view to advance the lifespan and quality of life for our brain tumor patients. It is a great honor and certainly a great pleasure to introduce our next speaker, Professor Dr. Adnan. He's a US board certified neurosurgeon and a professor and the chair of neurosurgery, Department of Surgery at the Aga Khan University Hospital, Karachi, Pakistan. He has a specialist certification in neurosurgery from Canada, as well as an FRCS from Canada, FRCS from Ireland, FRCS from Glasgow, and a fellowship of the American College of Surgeons. He has been awarded several accolades and honors for his work both in the USA and in Pakistan, including Physician of the Year Medallion, Master Surgeon Award, Excellence in Neurosurgery Award and the Presidential Award, Sitara Imtiaz. Dr. Anam has a strong interest in basic science research with a PhD in neuroscience from Northwestern University, USA. He is the founding president of the Pakistan Society of Basic and Applied Neuroscience and the founding president of Pakistan Society of Neuro-Oncology. A member of the executive committee of AANS CNS section of Brain Tumors USA, and a member of the advisory board of the Science Bridge. We will now go on to hear Professor Adnan Jabar's talk, which is Awake Craniotomy in the Perspective of Global Neurosurgery. Thank you.
Ji, Assalamu alaikum. Good morning. And I'm sure it's a good afternoon in different part of the world where people are watching this symposium. Thank you very much for inviting me to talk in this 20th Shaukat Khanum Cancer Symposium. I thank the organizers. This Cancer Symposium is the best in the country, done on an annual basis, and actually one of the best in the whole region. So I've talked about awake craniotomy in this symposium in the past also, but today I will talk about the data that has come out when I started awake craniotomy about 5 years ago in Pakistan. And I have more than 200 cases now. What has come up is that I never thought about it initially, but the awake craniotomy has a very significant role to play in a lower middle income country and in place where the resources are low. And it plays a very important role when we look at the brain tumors from the global health aspect, from public health aspect. So hence the term global neuro-oncology that I have coined, because that's the public health aspect of the brain tumors that we have to deal with. So I would like to talk about the, first of all, let me give you the disclosures. Those are basically none, no conflict of interest, and financially and otherwise. And I would like to talk about this case. It's a 63-year-old gentleman who came from up north. He was in a declining mental condition, very limited, bedridden, with moderate right hemiparesis. And he came with, his son brought him over here, who was 30-something old. Talking with the family, I realized that his son also had children, school-going age. I explained to the son about the disease. It looked like a GBM to me, Glioblastoma, and the possible treatment that we can do, which includes surgery and radiation and chemotherapy. The expenses that I told him would be pretty high, and on average, if we do everything on average, we may extend the life of his father by about 9 months. Whereas if we don't do anything, then it will be maybe 3 to 6 months. His question was that what other options do we have? And I said that comfort care is another option. I asked him about his financial resources. He said that he has a land that he tills, and that's his sole source of income. He can sell that off. That will give him about 12 lakh rupees. I told him that, you know, this whole treatment, if it's 5 lakh probably on average for craniotomy in those days in AKU, but then we can manage a welfare and that may be no expense to him. But then radiation, it depends where he gets the radiation done, his living expenses coming from north, staying here with the family, and then Temozolomide that he has to continue. So that may be more than 12 lakh rupees. And in the end, we may not extend the life of his father more than 9 months, and all his family resources will be drained. His children who are school-going age, their future will be severely affected. So I don't have any answer what to do or what I could do except for arrange a welfare at AKU for him. But he realized he was a very sensible man, and he decided to go back home and just provide a comfort care to his father. So I don't have a right answer, but this is what he decided. The other case is this 36-year-old gentleman who came from up north, and he had a low-grade glioma. It was a 1p19q code-deleted oligodendroglioma, and it was resected very well. This is immediate post-op picture, and he was supposed to follow up with me in about 3 months' time, but he never showed up, lost to follow up. And by the time he came back to me, it was almost close to 2.5 years, and the tumor had regrown. It had he was having seizures, so I told him that he needs to undergo surgery again. He understood that, but then he left, and I lost him again. I don't know what happened to him, but that highlights the point. So if he was living in the city of Karachi, for example, he would have followed up with me. Or if he had a lot of money, he would have, come back and shown me on a regular basis. And obviously, loss to follow up has other reasons as well. Although we try to tell our patients very clearly that this is what they have and they need to follow up on a regular basis. So the two main issues that come up in the public health management of surgical cases, one is affordability, and the other one is accessibility. And that was the reason that this supplement was published, and the chapter, one of the papers that I wrote on unmet need for surgery in South Asia, we talked about all those aspects. If you look at this graph over here, Pakistan is almost going to be in the top 5. And then if you put together Bangladesh, Pakistan, and India, which probably become the most populous country, we are talking about the major share of the world population in these 3 countries. And these 3 countries being in Asia, Asia itself has a very high amount of cancers. Of almost half of 18 million new cancer cases that come up, they are present in Asia. And then on top of that, the ratio of the oncologist and the cancer patients is very bad in the low middle income country, much higher number of patients per oncologist. And in that regard, Pakistan actually tops. We have the worst ratio in the world. This was data several years ago, but it shows that our ratio of cancer patients, new cancer consults per year per oncologist is much higher than India and Turkey and other low-income countries, even in Africa. And the public health aspect of cancer can be visually seen in this graph, which is projected, and it's the annual and cumulative GDP lost in low-income and middle-income countries from the 5 categories of surgical conditions. So if you look at this injury, which is red, and rest of them neonatal, maternal, digestive, and other diseases, the neoplasm is going to be a bigger and bigger menace over the next 10 years. About 50% of the world population lives on less than $2.50 a day. And when you put this together with the cost of this healthcare, no wonder there is about 44 million households that undergo every year a catastrophic expenditure, which pushes about 25 million households below the poverty line. And that is all because of their out-of-pocket payments, low household capacity to pay, and lack of prepayment mechanisms for risk pooling, such as insurance. The distance that they have to travel, as I showed in the second case, low middle income countries obviously are worse than the high income countries. And this is a data that we collected from the Pakistan Brain Tumor Epidemiological Study, which showed that about 50% of the patients had to travel more than 50 kilometers. But interestingly, or this is more important, that about 20% of patients had to travel for more than 500 kilometers. That's a large distance, and then that's why a lot of patients get lost to follow up. this all thing is further complicated by the issue of private sector and public sector. Although public sector institutions have improved a lot in Pakistan over the last couple of decades, but still there are issues of public sector and the issues of private sector. Private sector obviously is much expensive, beyond reach for most of the patients. And we are not so good in supporting our patients. If you look at this breakup of the current expenditure budget in 2020-21, look at the health, this little sliver over there, and look at the education, this little sliver over there. This is what we are really putting together for those two important aspects of our society. Our population with insurance stays very low, and the GNI per capita has gone down actually in the last couple of years, and we have at this point the GNI, the gross national income per capita of about $1,280. This is last year's. The cost of a craniotomy, even if you go in public sector institutions, there are some setups where there is no charge. But then in many public sectors, you still end up spending a lot of money in buying things. And if you go in a private sector, it can be on average $6,000 just for a clean cut craniotomy in and out without any complications. So put that against this per capita income, and that gives you an idea of why this catastrophic expense can lead to this catastrophic expenditure can push someone below the poverty line, or the family below the poverty line. There is a lot of effort that comes in terms of welfare disbursement. There are institutions like Shaukat Khanum itself, and then Indus Hospital, which are totally charity based. And then there's a lot of money that we pump in from our income, AKU being a not-for-profit organization. This is in 2017 about $22 million. And this actually has increased further over time. So we are putting a lot of money in, but still that may not be enough. So with all these issues, what do? We say, okay, let's see what we can copy from the West, and we take a square peg and push it down the round hole. It doesn't work like that. We have to come up with ways that are specific. We have to come up with guidelines that are specific for our situation. And I have published few things in terms of brain aneurysm, and there are a lot of other publications in cancer also. So that also applies to the brain tumors, and that's where we come to this concept of global neuro-oncology, looking at the public health aspect and how can we, living in a low middle income country, can help with that. So one of the first things that we need to do is build up a consortium. This Pakistan Society of Neuro-Oncology formed that about 2 years ago. We have started brain tumor study, brain tumor epidemiological study, which is PB test, and that has shown us a lot of gaps identified through PB tests. That's a whole different discussion some other time. But that's one way of actually starting to understand what the problem is, and we can do it for all the cancers, but for brain tumor, we did not have a good understanding what is happening across the country. We need to think about the twinning programs. We need to come to interdisciplinary neuro-oncology tumor boards. We need to look at telemedicine. The twinning programs can be both national and international, helping each other out. And then we need to think about the artificial intelligence, how we can, with the deep machine learning, develop some algorithms, softwares, and instead of actually going through a biopsy, one can diagnose it without a biopsy. So, for example, I have seen thousands of, several thousands of MRIs over the last 30 years. So I can very easily say that, yes, this is a GBM, and this looks like a lymphoma, and this was a biopsy-proven lymphoma. To someone who has just started to look at the MRIs, I would not be able to say that. And to someone who has not seen an MRI, is not a medical doctor, would not understand what these are. So in a way, one can have a system where the experience is not several thousands, but hundreds of thousands. And if you give that experience with deep machine learning and develop a software, then that it can diagnose very easily, not only these things, but if you feed in information about the molecular aspects, different things, the outcome and everything, it can all come together. And obviously that's why I call it a virtual biopsy. So virtual biopsy will benefit more us in an LMIC setting than anywhere else. So that's the need. We need to move towards that. This is an acoustic neuroma, for example, and all this is a miliary TB. We actually have developed a program, a software with reasonable prediction about the TB versus a tumor. And then not only that, the molecular epidemiology should be studied. WHO classification is moving more and more towards that, with IDH mutant, ATRX, and some of the histone genes, histone proteins and things like that. So not only the molecular epidemiology of the brain tumor landscape of Pakistan needs to be studied, but also samples should be obtained, and then we can study it further for microRNA, and then think about liquid biopsy. Now, if you come towards liquid biopsy, that's another way of actually avoiding a lot of this expense, non-affordability, and accessibility. So in the end, liquid biopsy is going to help the LMIC setting more than other countries. We don't need to go into expensive stuff, the expensive chemotherapeutic stuff, expensive gadgets, expensive radiation machinery, except for those which are needed. So I'm not talking about radiosurgery. Radiosurgery is very important, but still we need to cut down those expenses so that it is affordable to all the patients across the country. This is 5-ALA, which is used for detecting the tumor. You inject that dye in the brain, and the brain tumor lights up, so you can remove that tumor. Now, this drug itself is about $1,200, and the cost of craniotomy is about $5,000. So are we really getting that benefit? There is no clear-cut data that shows that it does create, it does give no clear-cut published data that shows that it does give a survival benefit. This is a gliadel BCNU wafers, and if you look at this medication, we put that after removing the brain tumor. It on average it gives a survival benefit of about little more than a month, but the cost of this is $11,000. At least that's what it was a few years ago. When I used to put it on a regular basis in USA in my practice, but I don't do it anymore because it's just too expensive. The price of craniotomy is $5,000. Why would we put a gliadel wafer for $12,000? And on top of all those things, we have to think about how we can use only essential technology to achieve good results. And that's what brings this to my mind, that we should train our residents to do that. We should train our team in Pakistan to do that. Only essential technology. So here is one of my patients with a GBM, and we have all these fancy toys and gadgets that we have. We do tractography and all that thing, but do we really need that? We can actually use awake craniotomy and intraoperative cortical monitoring, and we should be able to avoid a lot of damage to the tissues and get the best result. Now remember, the surgery for brain tumor is balance between how much you can remove and how much and how little deficit you can produce to the patient. So intraoperative monitoring is an important aspect. Intracortical deep white matter monitoring, and here is the result of that brain tumor patient with good recession of gross total recession of GBM. So this brings us to the study of the awake craniotomy, the excision of brain tumors, first 200 cases from Pakistan. This was compiled by Dr. Saqib Bakshi, instructor. The awake craniotomy basically is done by blocking these main nerves over here, and the patient is awake, may receive some sedation. So this is a patient. I usually do a small craniotomy, do a negative mapping to make sure that where I'm approaching it through, I don't have any functional tissue in that area, and the patient is being monitored at the same time for his movement of his arm and his legs, and his speech and visual comprehension and other comprehension. There's another case of an AVM It's an AVM, but it does show the same principles, where while removing the AVM, it's in the area of the speech center on the left side, and I was afraid that removing this AVM would leave this patient that deficit. But then while I was removing it, I could monitor her speech, and it went very well. But there was this little residual over there with that artery going inside. So I applied a clip over there, waited a few more minutes to make sure that that artery is not supplying any functional tissue. And after waiting, that it looked like it was okay. So that was removed, and that little residual AVM was also removed. And post-op angiogram basically showed that the AVM was totally removed. So this is the same principle that is applied in awake craniotomy also. So the primary objective of this study was to look at these 200 cases and then compare them with about 100 cases which had undergone a GA, and this was done over a period of about 2015 to 2020. And the outcome was looked at from the Karnofsky performance scale, basically. So if you look at the results, the mean age and the median duration, there was not much of a difference, but the mean hospital stay was much better in the awake craniotomy patients than the general anesthesia patients. Blues awake craniotomy, grays, GA, 3.15 days versus 5.26 days. The other parameters, male-female ratio and the histopathology was not too different. It did not reach statistical significance. In terms of extent of resection, it turned out that the gross total resection was, we were able to achieve gross total resection much better in awake craniotomy patients. Near total resection was also higher in awake craniotomy patients, and maximum safe resection was in the same way. Whereas the GA patients did not have that higher level of this good resection. The new deficits during surgery was much higher in those patients with GA compared to awake craniotomy patients. And the comparison of outcome, if you looked at the improvement of the neurological deficits, was again better in awake craniotomy patients. If you look at it throughout, the preserved neurology was better in awake craniotomy patients. And the KPS, the KPS deficit was slightly higher in awake craniotomy, but then the KPS deficit of 20, wherever it was severe disability, that was not as high. It was much better. However, this is interesting that in the late and early phase, in the late phase, this KPS deficit of 10 improved much significantly, although there was an improvement in the general anesthesia patients as well. But if you notice over here, the KPS deficit of 10 or more, or between 10 and 20, was a little higher, but then it improved over time. And the KPS deficit of 20 or more actually improved even further. And this is what the patients live with. Overall improved, overall preserved neurology, and the KPS, very few patients with KPS deficit of 10, and even very few patients with KPS deficit of 20 or more, and the p-value over here is 0.015. The pre-op versus post-op KPS, again, in the awake craniotomy group, there was a significant difference in the pre-op and the post-op KPS, and significant improvement that was 0.001, whereas in the general anesthesia group, there was not a significant improvement of the post-op KPS. And the comparison of the preoperative KPS between the two awake craniotomy and general anesthesia patients was not much different. But when we compared the post-operative KPS between the two groups, awake craniotomy had a much better Karnofsky performance score. So obviously, it showed that the surgery is a safe method of doing it. The recovery was better, the length of stay was shorter, the quality of life was better, and the resection was better with awake craniotomy, and it was more cost effective. So then it brings us back to the point that, all these expensive tests that if we can do it, that's good. We have it, we are doing it, we are doing tractography and all that thing, and neuronavigation and whatnot. But then to have this method of surgery affordable and accessible all over Pakistan, we need to train people who do not need these gadgetry and these tractography and these expensive things. Maybe at some time, inshallah, we will have this all over the country. But for now, if we can train them with awake craniotomy and to do those surgeries in a safe way, then that is the best way of dealing with this large volume of brain tumor patients in Pakistan. This is, in the end, I want to show this slide that my mentor, Dr. Ghaus Malik, when I was a resident and getting trained in Henry Ford Hospital, he said that since you're going back to Pakistan, I want to make sure that you learn how to do this cervical laminotomy instead of using expensive high-speed Midas drill. Just use a hand drill and learn how to do it. He wanted to make sure that I know these basic methods also, and that's what we need to teach and train our young residents. So this is the group of people who have worked with me for the Pakistan Brain Tumor Epidemiological Study and for this study as well. And this is important to mention over here, that know thyself, know thy enemy, and that's talking about the Pakistan Brain Tumor Epidemiological Study, 1,000 battles, 1,000 victories. And I'm really thankful to these bright and brilliant people who have come together and helped starting to answer a lot of questions about brain tumors. Thank you very much. If there are any questions, I would love to take it at this point.
Thank you, Professor Inam. Certainly an enlightening and superb talk on the global neurosurgery perspective, taking into account our own population having tumors. You have certainly simplified the answer for all of us, that we should keep it simple and try to achieve the maximum. And that's the way to go, awake craniotomy for gliomas. Certainly when I was coming back from Ireland, my mentor, Mr. Charlie Marks, took me through craniotomy with a jiggly saw, and certainly did show me how to do a laminectomy with a perforator. So again, even though we have trained in abroad, we have mentors who know that we're going back to a low middle income country, and certainly we need to change our ways and work with the resources and provide the best of care. Thank you very much again. So I'll introduce our next speaker. It's a great pleasure and honor to introduce Dr. Adam Green, MD, Associate Professor, Pediatric Hematology Oncology and Bone Marrow Transplantation at the Children's Hospital, Colorado, affiliated with the University of Colorado School of Medicine. Dr. Adam graduated from the New York School of Medicine and following his internship at the Children's Hospital, Colorado, completed training in pediatrics, followed by fellowship in pediatric hematology oncology at the Dana-Farber Cancer Institute, Boston Children's Hospital, affiliated with the Harvard Medical School in 2013. He was honored with the Young Investigator Award, American Society of Pediatric Hematology Oncology in 2017. He is a keen researcher, and his studies includes genetics and molecular pathways in diffuse intrinsic pontine glioma and pediatric glioblastoma. We look forward to Dr. Adam Green's talk focused on the present and future of targeted therapy for pediatric central nervous system tumors. Thank you.
Hello, my name is Adam Green. I'm an associate professor of pediatrics at the University of Colorado School of Medicine, and I'm a pediatric neuro-oncologist at Children's Hospital of Colorado. I'm going to be presenting today on the present and future of targeted therapy for pediatric central nervous system tumors, and I'm really appreciative of the chance to present. I'm going to focus my talk mostly on low-grade gliomas because that's the tumor where we've had the most progress with targeted therapies. And the talk will be fairly development and biologically focused, but at the end, I'll talk some more about a practical approach to using these therapies in children and what's being developed with targeted therapies for other pediatric CNS tumors as well. And I have nothing to disclose. So brain cancer CNS tumors have now become the leading cause of death from cancer in children, replacing leukemia. And this is as of a few years ago. And this is because, we have brain tumors that are very treatable, but we also have ones that are very challenging to treat. And even the treatable ones like low-grade gliomas can often be more challenging to treat as well, depending on their location and their biology. And so novel therapies, like targeted therapies, are very important to the development, to the outcomes for these tumors going forward. So we have started to do a lot more sequencing of patients' tumors over the last decade or so. It started out as very challenging, but has now become straightforward, much cheaper, much easier to do in terms of time, and is now a routine approach that we have at our institution. And so as we've started to sequence more tumors, we've found in low-grade gliomas a limited number of common alterations that I'll talk about, but also some rarer alterations as well. Most of the alterations in low-grade gliomas center around the MAP kinase pathway. And these alterations are really unique to pediatric low-grade gliomas and not found in adult low-grade gliomas, which are much less common. So this slide kind of summarizes the biology of these pathways. And you'll see that, again, the RAS, RAF, MEK, ERK pathway, the MAPK pathways are really where we're focused. And we have targeted therapies for multiple steps here in this pathway. The PA3 kinase, AKT-mTOR pathway is also common and can also be targeted. And FGFR is kind of one of the transmembrane receptors that's involved in this pathway. So some of the early signs that we got that targeted therapy might be effective in low-grade gliomas came from success with other tumors that showed the BRAF V600E mutation, which is common in pediatric low-grade gliomas. And so there was early success with the PBTC, Pediatric Brain Tumor Consortium trial, as well as large NIH trials treating plexiform neurofibromas in neurofibromatosis type 1 in children, here shown in these MRIs of plexiforms in the buttock of this child that improved greatly with targeted therapy with a MEK inhibitor. And so we're really finding that many mutations and other genetic alterations have been found in pediatric brain tumors and other tumors in general. As we've done more sequencing, we're really now able to target therapies to a lot of patients, mostly still on a clinical trial basis. So this chart here shows the pediatric MATCH trial, which is a trial through NCI and COG where we're basically, for recurrent tumors, targeting appropriate inhibitors to patients with whose tumors have alterations in that specific target. And there are several arms of this trial that are now ongoing. So as I mentioned, there are several groups in pediatric low-grade gliomas that are common alterations. So that's BRAF fusions, the BRAF V600E mutations, and the NF1 mutations, which come from, again, germline neurofibromatosis. And we've developed fairly effective therapies for these groups. But then, as this chart shows here, there are a lot of other alterations that come up in low-grade gliomas that have been slower to be targeted and are much rarer. So here we see the canonical BRAF KIAA fusion. So this is the most common fusion alteration that we see in pediatric low-grade gliomas. And it's, again, a fusion between the BRAF protein and its most common partner, KIA 1549. So this is a BRAF fusion, also known as a duplication. So basically what happens is that the BRAF N-terminal regulatory domain is replaced by the N-terminal end of KIA 1549. And so basically what happens is this makes this fusion protein constitutively active. So whereas RAS usually needs to be around to bind to the BRAF protein to activate it, now RAS no longer needs to be around for this fusion protein to be active. And this fusion protein characterizes or is almost always found, or the great majority of these fusion proteins are found in the pilocytic astrocytoma type of pediatric gliomas, which are WHO grade 1. So clinically, these fusion tumors are found in kind of specific parts of the brain. So they tend to be found in the cerebellum, in the brainstem, but less commonly in the temporal lobe and in the parietal lobe. And again, these are mostly found with the grade 1 JPA form of pediatric low-grade gliomas. So moving on to the V600E BRAF mutation. So this is a point mutation that's an exchange of thymidine to adenosine that leads to an amino acid change at position V600E, so valine to glutamic acid. And basically what happens is in the normal BRAF protein, the G595 to V600 segments are approximated to the G463 to V470 segment, which allows for hydrophobic interactions which close the catalytic cleft. But when this mutation is present, the catalytic cleft is open, and that again leads to constitutive activity of this mutated protein. And it's a very powerful change in that it can lead to a 500-fold increase in activation of the protein, which then stimulates MEK and ERK downstream in these tumor cells. And so here we see a map of the BRAF gene and protein, again, showing that V600E is by far the most common mutation found and is classically the one that's associated with pediatric low-grade gliomas. And V600E is not just unique to pediatric low-grade gliomas. It's associated with many types of tumors, both intracranial and extracranially. Classically, malignant melanoma is associated with V600E mutations, and that's where we've learned a lot about the treatment using target inhibitors for these tumors. It can be found in pilocytic astrocytomas, but is more common in the grade 2 pleomorphic xanthous astrocytomas and gangliomas in children. And even though they're low grade, these tumors can be quite aggressive. And so one series published by our group found that V600E mutations in gangliomas in the brainstem at this time were almost uniformly fatal, whereas non-V600E mutant tumors had a much better outcome. So certainly the site matters with these tumors. And these V600E mutations can also be found in some pediatric high-grade gliomas, which includes anaplastic pleomorphic xanthiocytomas and epithelial glioblastomas. So just as a case example, we had a patient with a ganglioma, again, thought to be, we don't like to refer to brain tumors in general as benign because they can cause a lot of problems by mass effect, but generally, these tumors aren't considered non-cancerous, but this was a patient with a tumor in the brainstem, like on that previous slide, so we know it to be life-threatening. We sequenced this patient's tumor and identified the V600E mutation. The patient initially underwent radiation, but rapidly recurred, and then was treated with the targeted BRAF V600E inhibitor vemurafenib and had an excellent response. And this was published as a case report of the first patient with a low-grade glioma successfully treated with vemurafenib, and that is back in 2013 now. And here is this patient's imaging. So we see on post-contrast T1 imaging here, this large tumor, kind of again filling a lot of the medulla and pons, and after vemurafenib, we have an almost complete response radiographically. So for most patients who have the BRAF fusion, those patients generally don't become resistant to targeted therapies. And so we can take them off of treatment. Usually we do that after about 2 years if they're still requiring treatment. And even if they then recur after that, they will again be sensitive to therapy if we start to retreat them. But with the VC-centered mutation, these patients often do develop resistance while they're undergoing therapy. And that's whether they're on single inhibitor or dual inhibition of both RAF and MEK, which is our standard at our hospital. My colleague Jean Mulcahy-Levy has done some really nice work looking at models of pediatric low-grade gliomas and showing that they indeed do develop resistance with chronic exposure to vemurafenib. And then she has been able to add inhibitors of autophagy, like chloroquine, to overcome that resistance. And so this is a patient who actually had a high-grade glioma driven by a BRAF V600E mutation, treated with vemurafenib and trametinib, but became resistant and progressed through those therapies, but responded nicely with a decrease in the tumor mass when chloroquine was added to that treatment. And chloroquine is now being tested as part of a combination for pediatric low-grade gliomas through a Pediatric Brain Tumor Consortium clinical trial based on this evidence. So just to touch on neurofibromatosis associated low-grade gliomas, these are most commonly in the optic pathways, and they are generally show a pilocytic histology when we look at their path. They don't always have to be treated, and we generally don't treat just based on imaging. We treat based on visual symptoms because we know that overtreatment is an issue. But if patients do have visual symptoms, we've generally been able to improve or at least stabilize their vision successfully with these targeted inhibitors. So we generally use MEK inhibitors for this purpose. And in most groups, MEK inhibition for NF-associated low-grade gliomas is now the standard of care. They can recur off therapy, but after age 10, they will generally not continue to progress or recur. Outside of the optic pathways, these tumors can also occur associated with NF, and those other locations, such as the brainstem, can be a much bigger problem, but again, can often be successfully treated with targeted therapy. A couple other fairly common genetic alterations associated with low-grade gliomas include FGFR1 mutations and fusions. And these are generally associated with grade 2 gliomas in kids and tend to be more infiltrative than other biologically driven low-grade gliomas. In older children, these tumors tend to be lower grade in grade 1. And the prognosis in general is related to the site of occurrence. And we're a lot earlier on with our targeting of FGFR1-driven low-grade gliomas in terms of use of targeted therapy. And so this is still being investigated. So this leads me to my last slide, where I just wanted to kind of give a summary of where we are with targeted therapy for pediatric brain tumors in general. And so I have a chart here kind of listing the most common types of pediatric brain tumors that we see by their cell of origin: glial tumors, neuronal tumors, and tumors that arise from cells that have an origin outside of the CNS. And I have some summary of these tumors here in terms of their location, metastatic potential, some predisposition syndromes associated with them, and our kind of overall approach to treatment in terms of what modalities are the most and least important to treatment. But I've highlighted basically low-grade glioma is the only tumor I'd say that we've really have progressed to where targeted therapy is standard of care with very few exceptions. But in yellow, I have highlighted some tumors where I'd say we've made a lot of progress with targeted therapies, and they're certainly being used in some patients off therapy, and certainly a lot of or off trial, and a lot of active clinical trial work going on in these tumors, high-grade gliomas, medulloblastomas, and ATRTs. Whereas the ones highlighted in pink were a lot earlier on with our use of targeted therapies, and it's really more investigational and preclinical at this point. So just to summarize our approach with low-grade gliomas, at our institution, we for grade 1 BRAF fusion-driven tumors, if surgery is still the standard of care, if they can be completely resected, that's usually curative, and we will not do further treatment if they can be completely resected up front. If we need to use medical therapy for the grade 1 fusion-driven tumors, we generally still use cytotoxic chemotherapy at low doses. We use carboplatin vinblastine. Carboplatin vincristine is a more common standard at other institutions. And then we'll use MEK inhibition as a second-line treatment, and we use trametinib as first line. As our for grade 2 tumors that have BRAF V600E mutations, we've actually moved to using dabrafenib and trametinib together as our first-line standard of care, with cytotoxic chemotherapy being a second-line treatment. And that's because these tumors tend to be more aggressive, and we've made a little bit more progress with the grade 2 tumors in terms of targeted therapies. And again, for both these, it tends to be effective. We use the 2 inhibitors together because that, especially in the melanoma literature, has been shown to decrease side effects, especially the risk for second tumors, such as skin cancers. We do see some side effects with these. They're mostly skin side effects and can be managed with topical therapies. We also follow vision because of the risk for retinopathy, and we follow echoes and EKGs because of the risk of cardiomyopathy with all of those targeted inhibitors. And we know that really sequencing and finding out what that alteration is in the tumors is really important, because in some early clinical trials, when BRAF V600E mutation was used for all low-grade gliomas, the patients who had the BRAF fusions actually progressed with BRAF V600E mutation targeted therapy because of a feedback loop that then activated CRAF. And so again, it's important to target the right inhibitors to the right genetic alterations. For high-grade gliomas, so kind of the current standard of care is still just radiation, but some of these tumors, as I mentioned, have BRAF mutations. We will use BRAF V600E inhibitors in those cases. And then there are some infant high-grade gliomas that have NTRK alterations. That's being investigated as a very potentially effective target. But some mutations in high-grade gliomas, such as the H3 mutations that characterize diffuse midline gliomas, are still being investigated because those mutations are not directly druggable. In medulloblastoma, generally it's the sonic hedgehog group that has been the target of most of the investigations so far with smoothend inhibitors. And in ATRT, there's a lot of interest in EZH2 inhibitors that can overcome some of the epigenetic changes that happen with ATRT due to loss of SMARCB1. So I'd just like to acknowledge our Pediatric Brain Tumor Research Group at the University of Colorado, the Morgan Adams Foundation Pediatric Brain Tumor Research Program, and especially Jean Mulcahy-Levy, Nick Foreman for their assistance with preparing this talk, and for our neuropathologist, Ahmed Ghilani, for the invitation. And thank you all for your attention.
Thank you so much, Ahmed. It was a wonderful overview of the molecular genetics. And I think we'll all have to train ourselves again, because the whole thing is changing altogether. Thank you so much. With that, I would like to introduce my next speaker. Our next speaker is Dr. Adnan Jabar. He doesn't need any introduction. He's a big name in the field of medical oncology. Dr. Adnan Jabar is a graduate of Dow Medical College. He's currently an associate professor and section head of medical oncology at Khan University, Karachi, Pakistan. He's board certified in internal medicine and medical oncology, and he completed his PhD as well. He is currently the president-elect for Pakistan Society of Medical Oncology. His work is tremendous in the other sites and fields of oncology as well. And I would like to request Dr. Adnan Jabar to give his valuable point of views on further advances in treatment in brain tumors.
Hello, everyone. My name is Adnan Jabar. Today, I'll be speaking to you about the molecular genetics and its implications in the management of glioma. Here are my disclosures. Today, I'll be talking about the glioma molecular overview, followed by the management of grade 2 and grade 3 gliomas. The classification of CNS tumors really changed in 2016. We know that the diagnosis of oligo now requires the presence of both IDH mutations and combined 1p19q loss. And we know that the tumors can still be categorized either grade 2 or grade 3. However, the prognosis, especially in terms of oligodendrogliomas, is not really dependent on the grade 2 and grade 3. It is more on the molecular subclassification, as I will discuss in a little bit more detail. So the prognosis, which is based on the histological subtypes, which is your traditional grade 2, grade 3, included astrocytomas, oligocytomas, and also your mixed oligoastrocytomas, and finally glioblastomas. But this classification is very, the prognosis is not very clear in all those. So, basically what happened was that the molecular subclassification came into practice, and traditionally based on this subclassifications, if you look at it, they are in general, divided into three major categories. The first one is based on the ID. The first step is the IDH mutation, which is further subclassified into either the presence or absence of 1p19q co-deletion. If you do have the co-deletions, these are the ones which traditionally are the oligos. But if you do not have the 1p19q co-deletions, you see a loss of TP53 and ATREX. And these are the ones which are now classified as your astrocytomas, grade 2 or grade 3, and also a small group of GBMs with IDH mutant, and I'll show you a little bit more in my next slide. And your third category is the IDH wild type, which includes the GBM. So looking at the various deletions, the low-grade gliomas, as I said, can be divided into your IDH mutated, and within that, the 1p19q co-deleted or the non-co-deleted. And if you look at their molecular profiling, there's a clear distinct between the two, where TP53 and ATREX is lost in your 1p19q co-deleted. This is a very clear different subtype, which is now considered as oligodendrogliomas. And the other one is the one which does not have 1p19q co-deletion, but have clearly TP53 and ATREX mutations, and the prognosis of of these is clearly different. The other subtype in the low-grade gliomas are the ones which are wild type for IDH. But if you look at the molecular profiling, it is pretty much the same in these two categories. However, if you look at the prognosis based on this, so the graph onto your left is one which is based on the traditional histological subtypes, but the graph onto your right is the one which is based on the new molecular classifications, which now gives you a very good distinct distribution of the outcome based on this. And what you can see here is now the low-grade gliomas, which is with wild-type IDH, clearly shows a prognosis which is much worse than your traditional GBMs, which are IDH mutated. So, which means that your traditional, low-grade gliomas, the morphological changes is not something that is all that is required for someone to, basically, it's not the main issue that will tell you what is going to be the prognosis of this. So now, with the incorporation of the molecular subclassifications, we know that the outcome in oligos, as shown to your left, is the same for grade 2 and grade 3. When it comes down to astrocytomas, in the overall, these also show you the same overall survival. Maybe a little difference in terms of, the two graphs separating out, but at the end of the day, their overall survival is also the same. And when it comes down to the IDH wild type, there's clearly there's a difference between the outcome. But once again, in the TCGA, there was, and whereas in the Suzuki's reported data, there wasn't. So clearly, we need more data to further prognosticate this subtype. So in summary, we know that there are three distinct subtypes, and the molecular subtypes trump the histological type. You have a histological oligo, but without 1p19q co-deletion, it is astro. This can be confirmed by the presence or absence of p53 and Atrex. We do have a histological grade 2, but because of the IDH wild type, their prognosis is very much similar to your GBMs. And then we have now seen that there are certain histological subtypes which trumps the molecular types, and that was the example of IDH mutated ones, which are typically low grade, but their outcome is very much like GBM. So our future trials must include these molecular subtypings, and we need more data in order to prognosticate the histological grade 2, 3 with IDH wild type gliomas. Moving on to the management of the grade 2 gliomas, which includes oligos and astros, we know that for any glioma, the extent of resection is fairly important, as shown by 3 promising trials, where when you had only biopsy, the survival was not as good as when we had complete resection or more than 90% resection. So based on all this, historical data, maximum safe resection is the key in the management of all these gliomas. However, when you have these subtotal resections in these grade 2, when you have recurrent disease or you have grade 3 disease, there is post-operative therapy required in most of these patients. Now, of course, we are talking about patients with MS, maximum safe resections, which are IDH mutated, 1p19q co-deleted with grade 2 oligodendrogliomas, and I'll talk about it in a little more detail later on. There may be a subgroup where observation might be okay, but this is the subgroup where you risk stratify them as low risk, which are younger patients and who do not have any symptoms. The data for giving radiation and chemotherapy was basically after the results of RDOG 9802, and I will discuss them in more detail. Very briefly, radiation therapy in low-grade gliomas, the timing and dose were addressed by these key trials. The non-believer trial told us that early radiation is important as opposed to delayed because it does improve the progression-free survival and it decreases the seizure rates. However, there was no improvement in overall survival. And the best dose was that there was no benefit of escalating the dose in overall survival of PFS as shown by the EORTC 22844 and then CCTG, where once again we saw more side effects of radiation as opposed to any benefit in the outcome. Low-grade gliomas are traditionally stratified based on these two, stratifications. The RTOG 9802 had subclassified them based on two aspects, that was age and also the resection status. However, Pignatti, he looked at and divided them into two groups, the low risk shown in the table below and the high risk. And the five features that, kind of divided them were the age, the diameter, tumor crossing midline, histological subtype of astro, and any presence of neurologic symptoms. And if anyone who has two features was considered low risk with a better outcome as compared to the high risk with a lower outcome as 3.2 years. The background for the RTOG 9802, which basically proved us that radiation and chemotherapy was important, was based on this historical data where Shaw et al. JCO and Buckner showed that when you add systemic chemotherapy to traditional radiation, in this early data, you did not see any benefit in the median progression-free survival. However, there was significance and there was a hint of significance in these patients, as you can see towards your right, as these patients survive longer. So it was more towards after the third and the fourth year when you start seeing these graphs, separating. This led to the actual trial, which was a phase 3 trial, which looked at is there any benefit of adding systemic chemotherapy to your backbone of radiation therapy. These patients were stratified into low risk and high risk, as I already talked about. And the high risk group was either given radiation alone versus radiation followed by 6 cycles of PCV. To note, these patients had a mixed variety of tumors. They were stratified and given high risk based on the age and the extent of excision of the tumors. It had mixed astros, oligos, and the group of oligoastros, which doesn't exist anymore. And they were also substratified based on the IDH mutations. And also to note here is that the IDH wild type were only 37% versus the 62% which were mutated. The results here once again showed that the addition of chemotherapy post-radiation had definitely an overall survival benefit. But this benefit was seen once these patients passed the 4-year mark. And, there was a clear overall survival benefit in these patients with the addition of PCV. Is there a difference between the histological or molecular subtype of brain tumors? We see that this benefit is seen in oligos, as shown in the graph to your left, and as well as in the astrocytoma. So whether it is your oligodendroglioma or astrocytomas, if you have high-risk patients, addition of chemotherapy is beneficial. Looking at the overall survival based on the IDH mutation, also the patients who were IDH1 mutated showed benefit in terms of addition of chemotherapy. This trial did not have too many patients who were IDH wild type, hence we could not analyze that, and also the status of 1p19q was not available. Mind you, this trial was before the actual classification that came up, the WHO classification. So after this trial, the standard of treatment became sequential radiation therapy followed by chemotherapy. And this benefit, as I said, was seen both in oligos, and also IDH mutated. However, this does not address whether the PCV helps in IDH wild type. The trial which showed in the anaplastic oligos, and I'll talk about it in more detail later on, also showed that there was benefit of addition chemotherapy in the IDH mutated and the co-deleted, which would be your mainly oligos, and the astros, which are IDH mutated and non-co-deleted. So the general theme is that PCV improves overall survival for people who once have gone past 5 years mark. So in summary, the RTOG 9802 clearly shows a survival benefit, which doubles from 7.8 to 13.3 for histological low-grade gliomas. And clearly, there is a benefit of addition of chemotherapy in these molecular subtypes of patients. There's another trial which is going to address the question whether PCV is equivalent to temozolomide. The name of the trial is Codell Trial. When it was initially designed, the original trial had 3 arms where newly diagnosed anaplastic gliomas who had the 1p19q co-deletion were either randomized to radiation therapy, along with concurrent temozolomide, followed by temozolomide in adjuvant setting, or just systemic temozolomide. But once this trial was started, the results of the RTOG 9402 came out, which showed that RT was worse compared to the addition of chemotherapy. Hence, ethically, RMA had to be discontinued. Well, not really discontinued, but PCV had to be added on to it. And clearly, there was, progression, 58 versus 13% on whatever patients they had seen. The RT arm had the worst overall survival benefit. So the new modified design for Codell trial, which is undergoing, is the addition of PCV to the RT and the STOOP protocol, which is concurrent temozolomide along with radiation, followed by 6 cycles of temozolomide. And also to note that before, these were only anaplastic gliomas with 1p19q co-deletion, but then later on they also added, based on the 9802, high-risk grade 2 oligos, which were more than 40 and has residual disease. So this will clearly give us some idea whether temozolomide that we normally use. There are phase 2 trials which show that temozolomide is equivalent, but this will be the real phase 3 data. So the current treatment paradigm for your low-grade gliomas in general is maximum safe resection, followed by post-operative MRI within 72 hours. And mind you, the 72 hours is very, very important, crucial in terms of, understanding what the residual disease status is. And then you select your low-risk patients for observation, but your high-risk patients are the ones which are typically going to get your adjuvant chemo-RT. These should be considered for early treatment, as I showed you in the Believers trial, and RT alone is equivalent to chemo alone. But we know clearly that the combination RT and chemo is better than any of these by themselves. PCV versus temozolomide is still controversial. Molecular data is fairly important in management of all your cases, and of course, multidisciplinary reviews, which are fairly important because without this, a good plan for your patient is not possible. So if you have a gross total resection, low risk, you can consider observation. But if you have high risk, clearly chemo-RT is the standard of care. If you have any residual disease and if you have just done biopsies, again, chemo-RT is the standard of therapy right now. Moving on to your grade 3 gliomas, oligos, and astros. We already talked about there are 3 major subtypes within this group based on their molecular subtyping. The IDH mutated ones with or without 1p19q co-deletion or intact. The co-deleted ones are the ones which will retain your attraxin p53 and are the oligos, whereas if they lose the attraxin p53 and they have 1p19q are the ones which are astros. And then the third type is the IDH wild type. These are the ones which will have the 1p19q intact, and we now do not use the oligoastrocytomas anymore. So after the molecular era, we know that the older trials showed us clearly that what we thought were homogeneous populations in our trials, grade 2, grade 3, was actually not true. We had at least 3 different types based on the classification that I just alluded to. And to reanalyze past trials, incorporating what we know now about the molecular is very confusing. So you have to bear with me in the next couple of slides. So the treatment paradigm, which is basically based for anaplastic oligos, is based on these 2 trials. If you look at the data from the RTOG 9402 and the EORTC, these are the 2 trials which showed in that addition of chemotherapy on the radiation backbone. And based on the initial publications from 2006, there was no benefit in progression-free survival. Adding PCV did not show any significance, as well as there was no significance in terms of overall survival. So if someone looked at this data, the early data, one can say, okay, anaplastic oligos, what's the point of adding chemo when there is no difference between the 2? However, the long-term follow-up of these same 2 trials, which was published in 2012, showed the patients who received chemotherapy either before or after radiation clearly shows a doubling in their median overall survival. And this overall survival, if you look at it based on the molecular subtyping, meaning if they were oligos, if they were 1p19q co-deleted, the benefit that you got from these was almost double, 7.3 versus 14.7. And this was not only in the oligos, but they were also in the astros. And astros, if you recall, they are the 1p19q non-co-deleted. But if you look at it, the astros did not show any significance in this 2012. So after this, the new standard of care, because there was an overall survival, became RT plus PCV. But this is not really true, and I'll tell you what it is. Because sequential chemo RT, even though showed no benefit, if you just clearly look at the 1p19q non-co-deletion status, if you further subclassify into and if you look at these graphs, once again, after 5 years, there was a subgroup within these anaplastic oligos that showed some benefit. And which were these groups? So if you look at the subclassifications or substratifications within these trials, this is your 9402, and the yellow graphs are your oligos, which clearly do much better than any one of the others. 6.8 versus 14.7, but within the non-co-deleted, if you substratify based on the IDH1 mutation, the blue one does better, but the IDH wild type does not do anything. And these are the ones which were behaving like GBM based on our molecular subclassifications. So looking at all this data, the final decision or the final understanding is that the oligos do well, the astros do well, but the non-co-deleted IDH wild type are the ones who do not show us any benefit of adding PCV in this subgroup. So this is basically the same slides, the molecular subtype oligos, the molecular astros, and the molecular GBMs. So now we know that we cannot have an oligo that is not co-deleted. We know that PCV, before radiation is better than RT alone for grade 3s. And the benefit of RT and temozolomide based on the Codell trial, and I'll tell you about that shortly, also there, this is your Codell trial, where basically this was a phase 3 trial, which was addressing whether temozolomide does the same thing to the non-1p19q deleted what PCV did. And this was a 2x2 design where you had 4 arms. patients who had confirmed grade 3 gliomas, they did not have 1p19q co-deletion, meaning these were astros, and they were substratified based on their MGMT status because we were giving them temozolomide. They were given radiation with or without temozolomide. And after this end of this round, you had, your the quarter one and basically interim analysis, and also you had another interim analysis which was after completion of the randomization to either no adjuvant temozolomide or adjuvant temozolomide. So looking at the data, when you look at the benefit of adding concurrent temozolomide to radiation, there is no benefit. The two graphs are just overlapping each other. So this was, the data after the first interim analysis, that the addition of temozolomide along with radiation does not give you any benefit, and this continued on the second interim analysis. However, when you give them adjuvant temozolomide after the end of after the end of their radiation, there is clear benefit of adding temozolomide to this group of patients, which are 1p19q non-co-deleted. If you look at the substratifications based on the IDH and MGMT, there is a difference. Patients who are IDH mutated, versus IDH wild type, clearly your astros do well, the molecular astros do well than the molecular GBMs. And MGMT methylation also showed a benefit in terms of the methylation resulting in more active temozolomide as opposed to the ones which are non-methylated in this group. If you look at the benefit of adding temozolomide to radiation, based on the IDH status, meaning wild type versus mutated, there is no benefit. So adding temozolomide did not add any benefit, whether they were IDH mutated or they were wild type. However, if you look at, in the wild type ones, but if you look at the IDH mutated types, once again, these were the ones which we had shown some benefit in the past as well. So adding concurrent does show slight benefit when you add the temozolomide to this subgroup. Hence, IDH wild type, not a good molecular type for you to treat, and there is no benefit. Same thing goes for adjuvant temozolomide. The IDH wild type doesn't give you any benefit, but when you give it in the IDH mutant, there is clear benefit of adding adjuvant temozolomide in this group. So the standard of care for anaplastic oligos, sequential RT followed by PCV or PCV followed by RT, that means combination, is what you should use in your 1p19q co-deleted, which now are considered molecular oligos. There's a clear doubling in median overall survival. Your astros, which are 1p19q non-co-deleted, but IDH mutated, also show a benefit, not as you would see in your molecular oligos, but there is a benefit of addition your systemic chemotherapy. And this was also confirmed by the Codell trial, where you have the benefit of adding adjuvant temozolomide. However, we did not see this benefit when you were giving them concurrently. And when this Codell trial was presented, the speaker did talk about it, that, we probably need more data because, when you are giving them adjuvant, not adding temozolomide in a patient who is tolerating temozolomide fairly well with no sign and symptoms, the expert did not see any reason why one should not add to radiation, even though we did not see any benefit. Clearly, the non-co-deleted IDH wild type grade 3, which are molecularly GBM, showed no benefit of adding PCV. They did not show any benefit of adding temozolomide, and they also showed no benefit of adding concurrent temozolomide. So you need to treat them like your GBMs. There are certain investigational IDH targeted approaches, like you have a IDH1 inhibitor, as opposed to you also have your IDH1 and 2 dual inhibitors. Both of these, drugs are in phase 1 and phase 3 trial, and we have a hope that they might be useful in patients who have this subtype of IDH mutations. So I'm going to conclude my presentation by showing this summary where if you have a grade 2 or grade 3 astro, these would be molecularly IDH mutated. These will be a 1p19q non-co-deleted, and they will lose your ATREX and p53. They will clearly show benefit if you add systemic chemotherapy, whether they are grade 2 or grade 3. There is an overall survival of more than 6 months and 5 months. This was explained very nicely in RTOG 9802 and 9402 respectively. So clearly there is a mutation benefit if they are IDH mutated. When it comes down to oligos, grade 2, grade 3, these are the ones which are IDH mutated. However, they are 1p19q co-deleted and they retain their ATREX and p53. There is clear benefit of adding chemotherapy to your radiation arm. And there is almost doubling, more than 14 years over the single arm. And once again, RTOG 98 was for your grade 2s, and RTOG 9402 and EORTC trial 26951 were the ones which showed this benefit. So clearly, grade does not matter in oligos. As long as your molecular subtype is treated similarly, the outcome is the same. 3 is behaving just like your 2. And finally, the last subgroup, which is your grade 2 or 3 IDH wild type, which molecularly behaves, like GBM. This is a provisional entity in WHO 16. You should treat them like GBM, treat them with, high dose chemotherapy, followed by 6 months of adjuvant, temozolomide, and the outcome is not as good as your oligos and astros. And once again, these were the trials which showed that there is no benefit of adding PCV, and we extrapolate the data of STUP for, treating these group of patients. So I'm going to stop here. I thank you all for your attention, and we'll be happy to take your questions at the end of the session. Thank you once again.
Thank you so much, Dr. Adnan. That was a very comprehensive review, and it added a lot and I think it made things very clear. And I'm sure everyone belonging to neuro-oncology and practicing neuro-oncology will benefit from this talk. So thank you, Adam, for joining us. I will request other panelists to join, and we'll have a short question answer session. Thank you, Dr. Adnan. And we have Ahmed and we have Dr. Atta with us as well. So I think we have a few questions. So there was one question, Adam, I think if you could answer. Do NF1 associated low-grade gliomas develop resistance to MEK inhibitors?
They can, but usually not if they stay on treatment. Usually they'll respond to MEK inhibition over time. We, as a standard, will usually treat them for about 2 years, and then stop and see if we can get a sustained response at that point. And if they recur after that, they'll usually respond again to restarting therapy. So they're not too aggressive in that way in terms of developing resistance.
Okay, thank you. And I think we have another question. There's a lot of overlap in the pediatric and adult gliomas, and we do see these gliomas in adults as well. Ahmed, would you like to answer that question? Should we classify these tumors in adults according to their genetic markers? And should we treat them the same, or would you think differently?
I think the treatment would follow the molecular subtypes. So you would treat the IDH mutant tumor if that that appears in a child somewhat similar to how you would treat it in the adult. Is that correct, Adam?
Yeah, I agree. I think we're finding it's more based on the molecular features than the age. And yeah, there's the overlapping, I mean, yeah, we certainly see IDH mutants, gliomas in teenagers and young adults whom we treat. And yeah, we would usually treat those as, per the adult approach when they have adult type molecular features. And similarly, if we occasionally see, K27 mutants, high grades in adults, those would, take the same kind of pediatric approach as well. So yeah, I think we're finding as we go along, learn more about the molecular features that it's the treatments, they respond based on molecular features and not necessarily just based on age.
Yeah, Adam,
I
we
would
have
like
another
to-
question. Yeah, sorry. Yeah, go on.
I would like to mention that for medulloblastomas, there's more recent data that's coming in that shows that even within the molecular subtypes, the pediatric patients and the adults behave differently. So I mean, our molecular markers have increased in the past like 5 to 7 years. So Dr. Jabar's talk didn't mention CDKN2A as a marker, which has been available after the studies that Dr. Jabar mentioned. So I think the adult and pediatric type and how they should be treated should be studied more.
Okay. And yeah, Adnan, yes?
No, I was just going to add, yes, there's clear data now that there is a difference in patients who do express CDK mutations versus, and that's in GBM, and that should be checked. But one of the challenges in a low middle income countries is the availability of these tests. I think that would be the major discussion if, we have all this data and what Dr. Inam just showed, that we are trying to follow all these recommendations in a country where some of these things are not even available. So.
Yeah, and actually, Adam, the next question was, there's a lot of overlap in the histology between H3G34 mutation, which is diffuse hemispheric gliomas, and IDH mutant astrocytomas. So if you don't have this marker available, how will you differentiate between the two? Because especially we have we have limited resources and it's not possible to do all these markers. Trust me, I think we have just been sticking to the basic panel. So what would you recommend?
Yeah, I think Dr. Ghilani could probably weigh in as well. I guess that there is a difference in prognosis, right? Because the G34 mutants, now classified as diffuse hemispheric gliomas, behave more aggressively than the IDH mutant ones. Yeah, I think it's a challenge because I don't think there's an IHC marker for the G34s like there is for the K27s. Is there a way to? Is there an easier test for the IDH that could then rule that in and rule out a G34?
That a question for me?
Yeah, just like is there an easier way to
I don't
rule in
think
the
so.
IDH?
I mean, there are some like OLIC2 is a stain which is expressed in one, not the other. But so you can have some hint, but not definitive diagnosis. But my question is, would you treat those two entities differently? Like how?
No, right. I mean, we would assume it would have high grade features, right? If it doesn't have high grade features, then it's unlikely to be a G34. Those are aggressive looking. So yeah, but if it has high grade features, yeah, I think our approach to that would still be if it's grade 3 or 4 to use. So in pediatrics would still be to use radiation with adjuvant temozolomide followed by temozolomide CCNU in those patients, and if it has a high grade glioma pathology, I don't think we treat it differently between the IDHs and the G34s.
Yeah, okay. And Dr. Adnan, just one question. So your data, you have explained in detail about IDH wild types, and we all know that they behave as GBMs. So they did not respond to concurrent and adjuvant temozolomide. Do you think we are moving away from STOOP trial then, and they're two different entities?
Well, we are not right now. That's the way you should treat them until more data comes in. There have been trials where patients who are, MGMT methylated versus unmethylated, other things have been used like immunotherapy. And clearly right now, we don't see anything that's better than what we are treating them right now. So unless something else comes on, your GBMs are treated similarly with your high-grade radiation plus temozolomide followed by temozolomide. We need more trials. I think these are the group of patients who needs more workup and more options. But unfortunately, the best thing that happened in oncology, IOs have not shown any benefit in this arena. That was the first ever negative trial for IOs. It showed results in every other subtypes of tumors except brain tumors.
And Dr. Irfan has 2 questions for you. I have just one question, being an oncologist. So do you have any quantitative way of telling us how much tumor has been removed? Is there any quantitative assessment, or it's by imaging only?
So there was a paper published, neurosurgeons. Maybe Dr. Irfan Yusuf is not a typical neurosurgeon, but neurosurgeons are a legend in their own mind. And then surgeons in general are a legend in their own mind. So there was a paper that was published, I think 2 decades ago, which clearly showed when a surgeon said, I resected this much, and then they did the MRI, they found it was 30% less than that. So in general, right? So I think now I see a lot of smiles on the faces of, these medical oncologists and pathologists. But the fact is, so that's why we came up with this protocol that we need to get an MRI done within 48 to 72 hours. So I would never depend on that, on your personal assessment. The best thing is to get the MRI, as I think Adnan or Ahmed mentioned that. And within 72 hours, even 48 hours is better. And now we don't have a software that we can actually do a volumetric analysis, but that's in the offing right now. And once you have that software which goes on top of that, then automatically you can tell. But you can do some rough calculations and get an idea. And it's interesting that when you look at it intuitively, it looks like that you resected only maybe half of it. But when you measure the volume, actually you have resected much more than that. So that's why I always teach my residents how to calculate the volume and all that. So that was one thing that you asked, right? Dr. Irfan had some.
Yes.
Yes, Professor Anand, thank you very much for your excellent talk. Certainly, it's a great leap of faith, going over from a patient asleep to a awake craniotomy and then working on the brain. Certainly, it involves a team effort. So I just wanted to know how long does it take to really achieve good results with awake craniotomy? I believe it's a learning curve for the entire team that includes operating staff, surgeons, and other people, including the speech therapists and neurologists and neurophysiologists.
Right. So Dr. Irfan, I was talking to Ugi Dufault. He's like the world authority on awake craniotomies. And he was very upset that we don't use neuropsychiatrists. But then we don't have neuropsychiatrists in Pakistan. How can we use that? So we have to use very limited resources. Now, you may think it's a leap of faith, but the fact is that just like you do in GA, you do it over here. You may have to take over from your trainees to make it go faster, but otherwise your surgical techniques appear to be the same in GA versus awake. The interesting thing is that it can be depressing when you start to see a patient developing some weakness. neurological deficit intraoperatively. You stop right there, and you walk out of the room very depressed. And then the data that came up after 5 years, it was just very interesting that actually all of these, not all of these, majority of these patients did get better. And the chance of improvement is remarkable compared to the GA ones. So we stop at the slightest weakness, slightest neurological deficit, and that is recoverable. So you may feel like, you're leaving a lot behind, but then think about in GA, you would have gone ahead and left the patient a lot more disabled. So I think, Dr. Irfan Yusuf, I'm sure you have done these things in Ireland, and a senior person like you, I think what we can do is teach the the residents, the trainees, these techniques very easily. I have done that over here, and they do pretty fast opening and closing. That's important aspect of that. And the team, obviously, anesthesia has to be in sync with you.
Thank you very much.
Thank you.
Sorry, there's one quick question in the chat box again. Is there any role of, Adam, maybe you can answer this question. Is there any role of CDK4/6 inhibitors in high-grade glioma, especially abemaciclib?
Certainly not standard of care. I'm trying to think if there's been investigation. So there is some early evidence, I guess, for ribociclib everolimus. That's a regimen that's under investigation for K27 mutants, diffuse midline gliomas. I think that there's a phase 1 that just finished and will probably progress to phase 2. There's a little bit of a signal, but for like hemispheric high grades, not really, but more to come.
Okay, I think with this, we are going to conclude our session. Thank you so much for being a part of this session. And I really want to thank you all for great presentations. And it was very informative. We have all learned a lot. And thank you so much. Thank you so much for taking time out for the discussion as well. Thank you.
Thank you for having us.
Thank you.
Thank
you. Bye.
Bye.
Thank you.
Hafiz.
Thank you, everyone. Hafiz. Thank you.